So our next presenter is Angela King. Angela is a registered respiratory pulmonary function tech. She is a registered respiratory therapist and a neonatal pediatric specialist. She has over 25 years experience in respiratory care, and in addition to being the Senior Director of Clinical Ventilation for ResMed and my coworker who saves me almost every day, she also has a business with her husband in which they care for approximately 25 patients in the northern Indiana area who are on ventilators presently. Angela?
Okay, thank you. Hello, everybody. Being a pediatric specialist probably isn't that helpful for the majority of this crowd, but I do remember last year there were a number of families here with pediatric patients, and I guess we have a couple today, so I'm going to try to work some pediatric information in where it's appropriate. We are awarding CEUs, and I think that continuing education units, and I think that came up earlier today. Someone had a question, do respiratory therapists ever have to keep going to school? And since I work for a manufacturer, I'm required to tell you this so that you know I'm doing the best I can to give you information today without bias. I'm not on a commission structure or anything like that, but to give you the best information possible. But you do need to know I work for ResMed. And as Brad already told you, I also take care of about 25 home vent patients. But RTs, please remember before you leave today to turn in your CEU form to me so I can give you your certificate at the end of the day. Just to make sure everybody's familiar with all the terms, we toss these terms around, and I just want to be sure that we're clear. The majority of patients can be ventilated non-invasively. That means nothing inside. But you can also see on the right some invasive patients and some ways that we ventilate patients invasively. This is an ET tube through the mouth, so obviously that's short term. Or we can use the tracheostomy tube, which is generally used for patients that are going to need ventilation. A rule of thumb is maybe more than 14 days. I was thinking in my mind while we were meeting this morning, out of our 25 patients, I do have 7 that are trached, but they were all trached except one before they came to us. I've only had one non-invasive patient transition to a tracheostomy. And just so you can see, just this past Thursday, I was on a conference call with one of my coworkers who was quite confused about where did the tracheostomy tube sit and could the patient still eat, or was that somehow in the same tube? So no, it's not. We can see here the little cuff. Now sometimes when we inflate this balloon, if we overinflate it, it sort of impinges here on the esophagus, and it might make eating difficult. But we also have to remember that it might be problems with the swallowing or secretion management that cause the need for the tracheostomy tube in the first place. So if the person had those swallowing issues, of course they're going to have those same swallowing issues when they're trying to eat. Being a machine person, I think a lot of respiratory therapists, we love the machines, and I thought it might be interesting for you to kind of see the evolution of all these wonderful new home ventilators that we have now. Obviously, our polio folks remember the iron lung. In my life, I've been practicing a long time. I have actually had 2 home patients that were still using the iron lungs. This has been a number of years ago, but I have had 2 patients who were ventilated very successfully for many years. And you have to remember how that worked. Although it was non-invasive, it was a negative pressure ventilator, so that's different than the non-invasive ventilators that we use now. The iron lung created a negative pressure around the patient that caused the positive pressure air from the room to enter the patient's lungs. So it's kind of an amazing story. We had plenty of these non-invasive ventilators available, but our European friends didn't. And in Copenhagen, there was one in the entire country, and there were only 6 chest cuirasses, which is another type of non-invasive ventilation that goes over the chest. And they actually had volunteers who signed up for 4-hour shifts around the clock and hand-bagged patients to keep them alive. It was an amazing, inspirational teamwork, I think. But I think the governments looked at that and they realized we've got to come up with a better way. What can we do if we need ventilation for large numbers of people? The iron lung really just wasn't practical. So then we started using positive pressure ventilation, and we pretty much did that invasively for everybody. And then we started in early 90s figuring out that we could use that positive pressure ventilator, but it didn't necessarily have to be invasive. We could use it non-invasively. Interesting, we're sort of going through a similar exercise in the last couple of years. You've probably heard about bird flu. And our government's been worried that we might not have enough ventilators for the population, so they've been stockpiling a lot of these smaller ventilators. So as you can see, this is a modern positive pressure ventilator. Now the home vents, we're very fortunate. We have a number of wonderful new home ventilators out now, probably numbering around 10 different types. And the challenge is to find the one that's best for your particular situation. Each ventilator has some special modes or some special features that may or may not be appropriate for your situation. At a minimum, a ventilator needs to have a volume or a pressure setting and also a breath rate. We want to be able to set that breath rate in case the patient isn't taking those breaths on his or her own. Now, somebody earlier today mentioned, I think it was Diana, that we might have a volume ventilator or a pressure ventilator, and we didn't get a chance to explain what those differences might be. Anybody guess how many milliliters this bottle would hold? This is a big bottle, by the way. Yes, exactly. So what we've got with a large bottle here is a large bottle of Coca-Cola. If you think about that, we can estimate, we could put a volume of air into the patient, a certain amount of air. We set a certain flow rate for a certain time, and that delivers a certain amount. And we can calculate that amount that the patient needs, kind of a rough estimate, by looking at their ideal body weight. And we say, for example, if the patient weighs 200 pounds, that's approximately 90 kilograms, approximately. So we could supply that patient 6 cc's per kilogram. So 6 times 9 is 54, so 540 milliliters, and that's where we would set the ventilator. Now that works perfectly if we don't have a leak. But if the ventilator is programmed to send 540 milliliters to the patient, but because his mask has moved a little bit, only half of it gets to the patient, obviously we would have a big problem. The other type of ventilation, which is more common, and that's the type most of you have been talking about today, is a pressure ventilator. And I'm showing this example of a man inflating his tire because that's something we're all familiar with. You inflate the tire to a certain pressure. The machine sends air until it reaches that pressure. And that's exactly what a pressure ventilator does. It sends flow until the pressure reading is whatever has been prescribed by your physician. But it's not sending a specific amount of air, it's just sending that flow until the pressure is reached. Also, it was mentioned earlier today that there are a couple major types of ventilators. There are those that you call a respiratory assist device or a leak ventilator, And then there are those that use a valve. I think Diana also mentioned that a little earlier today, a valve ventilator. You might be wondering, well, what's the difference? Why would I use one over the other? The leak ventilator has a single circuit, or the respiratory assist device, just has a single tube to the patient. So the inhaled air comes from the machine to the patient. But where does the patient exhale? Generally, there are ports on the mask that allow for the exhalation. Or we could add a little port in the circuit itself so the patient could exhale from some holes here. But normally it'll be on the mask. And as we mentioned earlier, it's very important that we make sure we have some flow going all the time, even when the patient is exhaling, because that flow from the machine is what's going to flush the CO2 out of the mask. Now, we could also use a valve ventilator, and there are a number of those out now for home use. And this valve ventilator sends inspiratory, one limb, and exhalation through another limb, or we could have a single limb here with the valve right in the circuit. Now notice on both of these cartoons, our patient, the mask is drawn blue, and that's because we're showing there's no exhalation through that. If you look on the tables today outside the room, if you look at the ResMed tables, you'll notice one table has masks that have blue bags and blue elbows, and another table that has the clear. The blue ones indicate that there's no exhalation ports. So as a consumer, if you ever accidentally got a mask with a blue elbow and you were using this type of ventilator, a respiratory assist device or a leak ventilator, you'd want to be very careful because that's not the right mask for you. A new book just came out, and I think Dr. Bendit had a chapter in there on, and I think Louis did too, non-invasive ventilation and weaning principles and practice. And the second chapter is by a very famous respiratory therapist, Dr. Dean Hess. And I got this slide from that chapter on what he's talking about, or what are some important things to keep in mind when you're thinking about what might be the right ventilator for a patient. One of the most important things is portability. People are on the go now. They're going here and going there. So we want to have a ventilator that facilitates that for them. This is the ResMed VPAP, and it only weighs a little more than 2 pounds. So it's very portable. And then we get to some other manufacturers, Trilogy, an LTV, and a new one from Newport. These ventilators weigh around 15 or 18 pounds, but they have an integrated battery. So depending on what your needs are and how long you might need battery power, you could choose the vent that was right for your needs. We also talked about the different kind of interfaces. Unfortunately, there are very few interfaces that are appropriate for a valved ventilator. Most of the masks available are for the leak type ventilators, so that we have the leak here in the mask. So if you have a particular favorite type of mask, you might need to use a leak ventilator just so you can use it with that type of ventilator. Just for a moment, I will say this is one of my preferred interfaces for ventilation because it's covering both the mouth and the nose, so it's comfortable for the patient because it's minimal bulk up around the eyes. Another thing to think about is the leak circuit is less complex because we don't have that valve up close by the patient. We have just the simple one line. So we don't need a dual limb circuit, we don't need 2 lines, and we don't need this valve up by the patient. But again, depending on the type of settings that are most appropriate for you and the type of ventilator, that will drive your mask selection. Now notice that this interface has the blue elbow that we were talking about. This is the elbow indicating there's no leak in this interface that we need to use the valve for the exhaled air. Another important feature might be something called a ramp. Some ventilators include a ramp feature, and generally the patient is allowed to adjust the length of time of the ramp. It's a little bit controversial, though, with ventilation patients, because what it's doing is starting you at a lower pressure and gradually increasing that pressure with the thought that you'd probably be asleep, so it wouldn't be so uncomfortable for you to be at that higher pressure. The reason it's a bit controversial, though, is because while you're at that lower pressure, you're probably not receiving the appropriate ventilation that you need. So this is a feature you would want to talk to your physician about or your respiratory therapist to determine if ramp was a feature that was appropriate for you. Another thing that might be helpful, some of the ventilators, just the leak type ventilators, offer a feature that allows you to test the fit of your mask to see if you're having a good fit or if you're having an excess leak. Obviously, if you have too much leak, you're not going to be in good synchrony with the ventilator. So we need you to have as minimal leak as possible. And this particular ventilator, a ResMed ventilator, does allow that little fit test so you can see if you're having a good seal or if you need to make some adjustments. Now, one of the things I also talk about, particularly with my pediatric families, is these ventilators are extremely advanced now, and they know about minimal leaks or minor leaks. And so the patient doesn't have to really ratchet that mask onto their face. And we were speaking with a gentleman this morning who already had some significant skin problems from just over-tightening that mask. So this feature might be helpful for someone like that. So you can see, hey, I have a good fit right now. I don't have to make it any tighter. Along the same lines, I think most people will say that they find the respiratory assist device, the ventilator, the leak ventilator, as more comfortable. These ventilators are designed with very robust algorithms to compensate or to measure these leaks and to compensate for them. Valve ventilators usually have a fixed bias flow. Now, my respiratory therapists will know what I mean by a bias flow. That's the flow during exhalation. The flow during exhalation is generally fixed at 10 liters on most of the home valve ventilators. So you might find you're considerably more comfortable with a leak type ventilator. Now, this might be a little tricky. When Gladys and I went over the presentation over the last couple of weeks, she knew we were going to have a good number of respiratory therapists. And actually, I was so thrilled I counted. We have 34 respiratory therapists today, so I'm so grateful. And I just wanted to point out, I know some of you have had less than ideal experiences with your respiratory therapists, but to have 34 that have given up a Sunday without pay, I'm just really grateful that they made that effort. So thank you for coming. But the challenge for us was figuring out how not to be too technical and for the majority of the audience, and yet still have the therapists come away with some new information. So I think here we're going to have a few technical slides. Here we're going to talk about how the ventilator works as far as the breath delivery. And we know we have 4 important points. We have when the breath changes from exhalation to inhalation. That's an important part. Then we have this whole inspiratory phase. And then what makes the breath change from inhale to exhale. And that's different on different ventilators. And then we have our expiratory phase culminating in our PEEP or EPAP. When we look at our ventilators, all valve ventilators offer an adjustable sensitivity. All valve ventilators offer adjustable sensitivity. Sensitivity is how we switch from exhale to inhale. How does the machine know that the patient wants a breath? Some leak ventilators allow this adjustment as well. I have one gentleman who is non-invasive 24 hours a day. And when he eats, we need to turn his sensitivity up a little bit because his leak ventilator is so exquisitely sensitive that when he's chewing and swallowing, it mistakes that for him asking for a breath. So when he eats, we simply turn the sensitivity up a little bit, and he finds he's perfectly comfortable this way. But we needed to have him on a ventilator that allows us to adjust that sensitivity. Another important feature, some people call this a comfort feature, but because it can also affect the volume of gas delivered, I kind of see it as both comfort and a physiologic feature. But it's called rise time. And almost all of our ventilators now have a rise time feature. And that controls how quickly we reach our set pressure. Okay, how quickly we reach. So some ventilators have 3 or 4 or 5. I know one even has 9 options for this rise time. Now, why is that so important, especially for the pediatric patient? Because if their inspiratory time is very, very short, which of course it is, and I choose a slow rise time, what do you suppose is happening here? Yes, and how many calls do you think I've received in my lifetime saying there's something wrong with that ventilator because it won't reach the set pressure? And is it the ventilator's fault? No, exactly. Somebody has chosen a rise time that's too slow to reach the set pressure. So that can be a problem. Now, Gladys and I were going over my slides yesterday, and she was talking about the opposite problem. If I have the rise time too fast, how do you suppose that might feel for the patient? I've got all this flow coming at me really fast, and that might be uncomfortable as well. So this is a setting that we don't get an order from the physician. Generally, this is a setting that the respiratory therapist needs to calibrate with the patient to find that perfect right balance. Oh, one other caution. A rise time of 1 on one machine, do you think that's the same as a rise time of 1 on another machine? Why, that would just be too easy, wouldn't it? So if you're on a rise time of 1 on a certain machine, don't assume that it would be the same on a different type of machine. You might still need to adjust that a bit. Okay, what are the modes that we have available? My goodness, I bet you didn't know there were so many modes available on these home ventilators. Generally, the mode is ordered by the physician. And we know today, we've already heard lots of people talking about perhaps the wrong mode was ordered for them. Perhaps they were ordered CPAP, or they were ordered bi-level S, not with a timed backup rate as well. So the modes are important. Different ventilators offer different modes, so that can make it a little more challenging for us. But the modes that we refer to bi-level ventilation have two distinct pressures, an inspiratory pressure and an expiratory pressure. But not only do we want to have 2 pressures, for your needs to function as a ventilator, we also want to have that backup rate as well. Now, I realize it sort of becomes like alphabet soup. We have an awful lot of acronyms that we toss around. So some of those, just to make sure we're all on the same page, we talk about BiPAP, but that's a trademark of Respironics. Other folks will call that bi-level. We call it VPAP. You could also call it non-invasive positive pressure ventilation, or you might write it this way. Some people, particularly respiratory therapists in the hospital, will refer to it as pressure support because that's what it's called on the ventilators that they're using, or non-invasive ventilation. But in a nutshell, that's a lot of different ways to say 2 levels of pressure. Now, once again, do you suppose the settings on one type of machine would transfer exactly to another? No. It's very important, especially if you're going from a leak device or a RAD to a valve device and vice versa. You want to make sure the pressures are equivalent. Now, some machines, when we set an IPAP of 20 and an EPAP of 5, that delta or difference, we call that the delta, or if you're a Dr. Bach fan, you call it the span, that's 15 centimeters. But typically, our larger hospital ventilators or our valve ventilators, if we have an EPAP of 5 and we set the pressure support to 20, typically there our span or delta will be 20 centimeters. So it's not necessarily enough just to know what your 2 levels are. You have to know if your device is compensated for that EPAP level. Now it's going to get a little bit more technical, so my RTs will be up on their toes. We have to think about how does the ventilator know when the patient's ready to exhale? How does that device know when it's time to switch from inhale to exhale? Well, most of the ventilators allow some adjustment here. Unfortunately, this is an area I think as respiratory therapists that we're sometimes weak in because we don't quite understand it. Most valve ventilators do allow us to adjust this, and some leak ventilators do. I know the ResMed device gives us lots of options to adjust here. But here we are. This is a flow waveform, and this is pressure. So we can see this is the inspiratory flow, and as you take a big breath, you reach a peak inspiratory flow, right? Right here. The peak flow as you're pulling in that air. But as your lungs start to fill up, what's happening to that flow rate? As your lungs fill up, what's happening? That flow rate is starting to drop. And the ventilator is watching that. And when it drops to a certain percentage, in this example, the percentage is 40% of the peak. So let's just pretend this is 100 liters. When it drops down to 40 liters, it allows the exhalation, or it cycles to exhalation. On this side, the therapist has set the cycle sensitivity all the way down here to 10% of the peak. So we have our peak inspiratory flow, and the flow starts slowing down as the lungs get full, and when it drops all the way to 10%, we cycle to exhalation. Make sense? Now, what happens if there's a big leak? If there's a really big leak, do you suppose this flow is going to drop? So what will cycle that breath? Oh, that could be a problem, couldn't it? Sometimes I call that getting stuck in inspiration. And we then have dysynchrony with the ventilator. You're trying to exhale, but it is still sending flow at you. So you're not going to be optimally comfortable. So this is an area that we need to learn to adjust for each individual patient's needs. Now, of course, we call it different things. Some machines call this a flow cycle, and other machines call it the expiratory sensitivity. Now, this particular machine offers 2 options. If the breath does not flow cycle within a certain amount of time, it will stop the breath anyway. It will say, okay, this is the maximum time I'm going to allow you to inhale. It's kind of a safety feature. Some machines offer this feature, and I think you'll see here the ResMed machine does offer this feature, and so do some of the other valved ventilators. We call it the TI max. So what you can see here we have our IPAP level and our adjustable rise time. So here was a very fast rise time, here was a little slower rise time, but we got to our set pressure. Now normally, the patient will flow cycle the breath. As the flow drops, the machine sees the flow drop and it cycles to expiration. But if we had a large leak for whatever reason and that flow did not drop, the machine will take over for you. We call that the TI maximum. The machine will take over inspiratory time maximum and end that breath for you. Now some other modes that we have, once again, by different machines, we call them different things. But some of the modes available for you, these are some valve ventilator modes. On this particular one, this is a pressure setting. This is very common for my pediatric patients. This is called pressure control. I come up to a set pressure and I stay there for a certain amount of time. It's not flow cycled, it's time cycled. A certain amount of time for each and every breath. Very common for the kids. We also have here SIMV, synchronized intermittent mandatory ventilation. And this is a mode on the valved ventilators. So we have some machine breaths and then we have some pressure support breaths mixed together. Our most common mode on the machines that most of us are talking about today is our ST mode. And you might wonder, what does that mean? What does that mean? ST is synchronized timed. So we're going to have our IPAP setting, our inspiratory positive airway pressure, and our expiratory positive airway pressure. Now do you see this little deflection here? That means the patient asked for that breath. It wasn't just given to him, he asked for that breath from that little deflection. And this particular breath was held to what we call the TI minimum, the inspiratory time minimum. Now we believe this is a crucial feature for neuromuscular patients because this mandates that you had to hold that breath at least a certain amount of time. Particularly the patients that have severe restriction, the severe kyphoscoliosis. Sometimes if we push that IPAP in, because of the restriction, it comes right back out. So this particular feature, this TI minimum, it says you have to hold that breath at least this long. Now, once they've held it that minimum time, then there is also a maximum time. It's sort of like parentheses around the breath. There's a minimum and there's a maximum, but the patient has the ability to breathe in that time period what's most comfortable for them. The valved ventilators do not have this option, this very important option. The closest is a valve ventilator that allows the breath to either flow cycle or time cycle. But none of the valve ventilators that I'm aware of allow both the TI minimum and the TI maximum to be set. Now this is one of my dear patients. We've been looking after him now for almost 5 years. He's on a mouthpiece ventilator. And just like Dr. Bendit says, we need him everywhere in the country. I come from Indiana, so we don't have a lot of expertise with mouthpiece ventilation there. They wanted to trach him because they didn't think there was any other option. But we talked him into trying it. He raises puppies and he works. And you can see he's 24 hours a day on a ventilator. Now he is on a valved ventilator during the day and a leak ventilator at night. Because in the valved ventilator, this is from Dr. Bendit, he wrote an article on just this subject that was published in Ivan News. Volume ventilation is best for mouthpiece because it can avoid auto-cycling and allows that breath stacking. Remember, Dr. Bendit talked about increasing the breath, so we can take a breath and another, stack them up. Oxygen delivery is probably not very important for this group, but some ventilators allow a higher oxygen concentration to be delivered. This particular one uses this bag to deliver up to 80% oxygen, which is not anything that this group probably needs, but something to keep in mind. So when we're looking at what are the best devices for us, we have to think we can move from the simple ventilators or the ventilators that are used primarily for those patients who have a tracheostomy or who are 24 hours a day, very dependent on that ventilation. We also have some ventilators that are approved for the very small patients, the pediatric patients, and some that you need to be a minimum of 30 kilograms of weight or higher to be on this type of ventilator. So there are a lot of options out there, and ideally you would have a consultation with your therapist and physician to figure out what was the best one for you. For our monitoring options, we do have a wonderful amount of data. Generally, I think the leak ventilators offer us more data about the patient than our valve ventilators. The leak ventilators tend to give us data over time, where the valve ventilators show us the data right now, but it's only in the real time. Now, Gladys specifically asked me to cover this screen. This is some of the information you can get from your home ventilator that might be helpful for you. This particular one is showing me the mode and that there is a ramp set. It's also telling me the EPAP and the IPAP pressure, so 4 to 10 is a pressure support of 6. This particular breath was triggered by the patient. That's called a spontaneous breath, and it was cycled also by the patient, not by time, but by the patient. We also can see the leak, the respiratory rate, the patient's minute ventilation, and tidal volume. And finally, we have one other screen that will show, again, who triggered that breath. Spontaneous means the patient, T means the machine, and what cycled that breath. This one was held to the TI minimum. The patient was held at that minimum time before the machine released the breath. It also gives us the inspiratory time and the ratio of inhale to exhale. Now, over time, you might find that this data is helpful for you. Gladys gave me permission to share this information, which is exactly from her ventilator. And you can see Gladys had some days here, 8:28 and 8:30, and she records her leak every morning. She puts it in a little spreadsheet every day. What percent of the breaths did she trigger spontaneously versus what percent did the machine give her? What's her average or her apnea-hypopnea index, her minute ventilation, her average tidal volume, and then she has a column where she keeps her notes. Now, Gladys in her own life feels that there's a correlation between days that she overworks or overdoes it physically and the percent of spontaneous breaths that she has. When she's more tired, she rides the vent more. That's what we respiratory therapists call it. She rides the vent. So she's sleeping so deeply, resting, the machine is kind of taking over for her. Now, we don't have published studies on this. This is from Gladys's personal observations. We can also get a lot of data out of your little card. I don't know if you've ever gotten to see the data that you get from your card, but here's an example. Okay, in closing, I wanted to show you that there are so many different ventilators out there. It's hard for us as respiratory therapists to keep up. So I know it's probably hard for the patients and their families. So just feel free to ask a respiratory therapist or your physician. But I also know I get a lot of questions from people who think that going on that ventilator 24 hours a day would be the end of the world. And I wanted to share with you what I think is a fabulous study from my hero, Dr. Bach. He looked at 621 vent patients and 256 healthcare workers, and he asked them to rate their life satisfaction. So I'm going to ask you to do that in your mind right now. On a 1 to 7 scale, 1 is you're very unhappy, 7 you're very satisfied. So think about what your number is. You got your number? Okay. Now meet my friend MJ. She is an SMA patient. I do have her permission to share her story. She can't use her hands, almost not at all anymore. She was using a mouthpiece. She's recently been trached. But 24 hours a day, she's on the mouthpiece. At night, she's on a mask. Very, very limited motion. She does have a feeding tube. What do you think her life satisfaction would be? As you're looking at MJ's life and limitations that you see, please think 1 through 7 where she might be. You got it? Okay, now what did the real data show? Well, the healthcare workers averaged 5.33 for their life satisfaction. The trach patients, 4.68, and the non-invasive patients, 5.04. So statistically, almost no difference in these 3 groups. But when the healthcare workers looked at the ventilated patients, what did they think? Oh, I bet their life is really unsatisfactory. So I think there's a lesson in there for all of us that you can still live a high-quality life even if you're on the ventilator 24 hours a day. The challenge is working with your physician and therapist so that we can get things as close to comfortable for you as we can. Now this little smiley face, that represents where MJ scored herself. And I would like to see you have a look at MJ graduating with honors, by the way. She is now a full-time student at Wright State University, soon, very soon to be a rehabilitation therapist. So in the end, I know we've heard some negative things about respiratory therapists, but we'd love to work with you and help you.
So questions for Angela? Any questions?
I see one hand.
Okay. In the back? Right up here.
I'm a sort of respiratory therapist that also has ALS, and I'm involved in participating at local ALS support group. And a number of times I hear complaints about nobody is willing to fit them with the proper nasal mask or full face mask. And mask is one of the major hurdle in terms of almost success and non-success with bridging over to BiPAP. And another thing I'd like to find out is how a patient is able to try out different types of machines. For example, you know, I was given a BiPAP from Respironics, and that was the only machine that I was given, but there hasn't been any opportunity where someone has come along and said, hey, would you like to try this machine, or would you like to try valve or non-valve machines, that sort of things?
Right. I think it's a very important question, and I'm sorry I don't have the greatest answers for it. For trying out the machines, the one thing I would say is it's important that you do it as quickly as possible. Because once your machine converts to a purchase, it's going to be very difficult for you to try other machines. The ideal would be you're trying, see as many as you can before you commit to one, and then try that one, and as early as possible, within the first few months, is when you want to be asking to try the other machines. Now, you're also eligible for a new machine. I think it's every 4 years. 5 years. So, but that's a long time to wait on the wrong machine. So I urge you to make sure that you're asking all your questions up front and ask to see the other equipment that's available. Yes, Diana had a comment?
Unfortunately, some of this is insurance-driven, which is disgusting. Yeah, a lot of it is. However, the good news, if you're under Medicare, there really are a lot of options. If you're already on a bi-level device, even if you own it, you're still eligible to get a volume ventilator. And some of the volume ventilators can operate in many different modes. And Medicare does allow you to have both a bi-level machine and a volume ventilator. And if you get to the point where you need to have 2 volume ventilators, you're eligible for those too.
Question.
Yes, my machine, I have a ST. It's 5 years old, and it's beginning to give me a few problems. So it's the same machine that Gladys uses. We got them both at the same time pretty much. I'm interested in, number one, how do I get those numbers? My machine, when it came, didn't have the instruction book in it. So
Well, if you stop at our table and I'll give you my card, I'd be happy to make sure you get the booklets.
Oh, okay.
Absolutely.
But anyway, my machine right now, for example, when the button you push to turn the heater on and the humidifier, as soon as I push that on, everything goes full blast. And then I reach back, turn off the machine again, and then restart the machine, and then it works fine, you know. So I figured it must be time to replace the machine. So that's...
Well, you stop by our table and we'll get you fixed up.
Okay, thank you.
So we had
Question in
another.
the back.
Actually, my question is for jury and for the respiratory therapists who are here. She's a respiratory therapist who has ALS. And I asked her a very pointed question about breathing. And I'd like for jury to answer this for all of you. I asked her how much of an impact on her longevity, because she's at year 5 with ALS, which is highly unusual. It's reaching into the upper limits. How much of her longevity is because of her respiratory support? And I'll let her answer that.
Thank you, Gladys. I have been using, like Gladys said, bilevel therapy from the day one I was diagnosed, almost exactly 5 years ago. And I have to say that being on the BiPAP really gives me energy, renewed energy even during the day when I'm fatigued and I'm all used up. I just go on a BiPAP for half an hour for a power sleep for half an hour to an hour, and then I am regenerated, rejuvenated, and good to go for the rest of the day. And so without the BiPAP, I would think that my life would not be as active and as fulfilled and enjoyable. So I highly encourage people to make the utmost effort to work with the healthcare professionals and just persevere and then make sure that you get the type of settings and type of machine, type of interface that you are able to live with and live with style very well. Thank you.
Awesome. Thank you.
Hi. I just want to say thank you to you for saying that, because as a respiratory nurse in home care, and you can see from all the questions that are in the room, people have had bad experiences, and then they come to me, and I'm trying to show them how to use the CPAP or the bilevel that's prescribed. And again, in trying different machines, you have to remember that as the clinician, we're driven by the order from the doctor. So if the doctor orders a specific machine, that's the machine that we have to use. at Progressive Medical, we do things a little differently because we do get a prescription to titrate to effective therapy. But I have an issue with a lot of patients with neuromuscular diseases. They don't feel like they need that machine when they're first diagnosed. And I would love to know what the answer is to that question when they ask me, you know what, I don't really need this. You guys are just trying to make money off of me. Because that's not it. And I wish I could have a video of you to show the patients when they walk in the door. Thank you.
Okay, Angela, thank you very much. Outstanding presentation. Oh, another question? I'm sorry.
She's going to respond.
Oh, I just wanted to make a quick response. I think that since this change in the breathing apparatus in our body happens in a gradual process, I think that patients don't have the realization that they are actually marching towards a problem. I think it's a therapist's job to try to get some data that might be convincing so that the patient can actually see the numbers. But patients really don't realize how much they've been missing until they acclimate towards bi-level therapy oftentimes. Thank you.